to treat and challenging to diagnose. So to start, between 10 to 20% of the patient dying of this mented cancer have metastasis to the heart. The incidence of the primary cardiac neoplasia, just primary, originating from the heart, it's between 0.17 and 0.19 in unselected autopsy series. The good news about this is that 75% of the primary cardiac tumor are benign and 25% are malignant. And out of these 75 of benign tumors, 50% of them, they're actually Mixoma. And on the malignant side, 75% of the malignant tumors are sarcomas. Ectopic thyroid tissue may occur within the myocardium, and it's referred as stroma cordis. So if you hear about the stroma cordis, this is a thyroid tissue that went to the heart. So as you can see here, this table actually was taken from as you see here, the type of the cardiac tumors. The type of the cardiac tumors, you can go through the table, but there is something like we called pseudotumors, which is neurothrombi, heterotopsis and tumor of ectopic tissues, such as tumors of adrenoventricular node regions, teratomas, ectopic thyroid, as we discussed, tumors of mesenchymal tissues, such as hamartomas of endocardial tissue, Biliary Fibroglystomas, hamartomas of the cardiac muscles, rhabdomyomas, histocytoid cardiomyopathies, or we call Purkinje cells hamartomas. Or it could be originating from the fat, and this is, we call it like lipomas hypertrophy, or intraatrial septum lipomas, or liposarcomas, or tumors and the neoplasias that originate from fibrous and the myofibroblastic tissues. So any tissues in the heart, either muscles or fibrous tissue, can originate abnormal tissues. Tumors from neoplasia from the fibrous and myofibroblastic tissues, such as a fibroma, or inflammatory pseudotumors, such as inflammatory myofibroblastic tumors, or sarcomas. And this is the most common malignant tumor, which is malignant fibrous histocytoma, or fibrosarcoma, or leiomyosarcoma. Or it could be vascular, originating from blood vessels, such as hemangiomas, epithelial hemangioendotheliomas, and angiosarcomas, and neoplasia of uncertain histogenesis, such as a Mixoma. Mixoma, we don't know exactly the histogenesis of Mixoma. Neoplasia of the neural tissue also we could have schwannomas, or neurofibromas, or ganglion cells tumors in the heart. We could have also paraganglionoma, malignant schwannoma. This is also rare entity, and malignant mesotheliomas, and metastatic tumor to the heart. So as we discussed before, the most common tumors of the benign neoplasia, it's Mixoma. So it's like I said, like 50% of the tumors, it's Mixoma, followed by lipoma, followed by Biliary Fibroglystoma. So this is a very typical exam question. He will say, name the 4 most common benign cardiac neoplasia. So you need to know that the Mixoma is the first, lipoma, the Biliary Fibroglystoma, and hemangioma. This is the most common tumors that you will deal with during career. You could see very rare kind of tumors, especially in the high volume center when they deal with this kind of cases, such as AV node mesotheliomas, fibromas, teratomas, ganglion cell tumors. And as you could see, once you go down the list, the percentage of these tumors goes like less than 1%. Now, benign cardiac neoplasia in children is different than the adults. You have to know this. This is in the adults. In children's, you have to know that even the age plays a difference, okay? However, the most important or the most benign cardiac neoplasia in the children, it's rhabdomyoma. And this is related to another systematic disease, which we're going to discuss later. However, you need to know, because sometimes in the exam, they will ask you, name the most benign cardiac neoplasia in the children. So you need to know it is rhabdomyomas and teratomas, and then fibromas, okay? And followed by the hemangiomas. So Mixoma, as we discussed, the Mixoma is the most common benign tumor, and 75% of all cardiac tumors are benign. So myxomas comprise 50% of all benign cardiac tumors in adults and 15% in children. So the deoxyribonucleic acid, which is DNA genotype of a sporadic myxoma, is normal in 80%. So 80% of the cases, they're non-familial. This is just a sporadic finding. Myxoma are unlikely to be associated with other abnormal conditions and have a very low recurrence rate. This is very important, okay? Because as we're going to discuss later, some of the other benign cardiac tumors, it's related to other systematic disorder. But most of the myxomas did not associate with abnormal conditions, and it has very low recurrence rate. 5% of the myxoma patients have a familial pattern of a tumor development. And this is another important question. So they will, if you get asked about what are the recurrent myxoma, this is only 5% of the myxomas, and they have a familial pattern, which is autosomal dominant inheritance. All familial and the 20% of those sporadic myxoma have abnormal DNA and genotyping. And this is usually happening in the young patient, multicentric and high recurrence rate. There is a very important thing you need to know, something called Carney's complex. And this is actually, we've been asking these questions actually in our Royal College exam. It will ask you, what are the genes associated with this? You will say PKR1A, which is other genes with short arm of the chromosome number 2 and chromosome number 12. It's an autosomal X-linked inheritance. It's primary pigmented nodular adrenocortical disease, hypercortisolism, cutaneous pigmentation, lentigonesis, and cardiac myxoma. This is, they might ask you about what are the relation between myxoma and Carney's complex. So you need to know the genes. You need to know what is the other features, which is adrenocortical disease, hypercortisolism, and there is a pigmentation, and there is also cardiac myxoma. So the pathology, the atrial myxoma generally arise from intra-atrial septum, and this is very important for you to differentiate between, because sometimes it's very hard to differentiate, especially if the myxoma has been there for a long time. Sometimes it gets calcified, and it will be very hard to differentiate between myxoma and between sarcomas or other cardiac tumors. So usually it arises from the intra-atrial septum at the border of fossa ovalis, but at the same time, you need to keep in mind it can originate anywhere in the atrium, which including the atrial appendage. So the most common feature of myxoma when you operate in these cases, it's usually round or oval, smooth or lipillated surfaces. It could be polypoid, could be compacted, it could be pedunculated. It's mobile and not likely to be fragmented spontaneously. So if you look at the histologically, like histological studies of myxoma, so it's composed of the polygonal shaped cells and capillary channels within the acid micropolysaccharides matrices. Why I'm bringing this? Because this is all could be multiple choice questions, could be essays questions. So you need to know where does it originate from, how does it look histologically, and you need to know that how this tumor gets fed. It has vessels or like vein and arteries that connected to the subendocardium of the heart, and there is associated there is occasional presence of hematobiotic tissues and bone in these tumors. Myxoma can develop after also cardiac tumors. This is very important. Like if the patient going for any procedure that required transseptal, such as balloon valvoplasty for the mitrals, patient going for AP studies and ablation, all these can result into at the site of the puncture, the patient can develop myxoma. This is one of the risk factors. So how does this present? This is a very important also to know how these patients present. They can, the most common form of presentation, it's intracardiac obstruction, and this is lead to congestive heart failure. This is 60%, 67% of the time. They can present in an embolization such as stroke, limb ischemia. They can embolize anywhere, or could present with the systematic or constitutional symptoms. And this is another important. I've been asked about this actually in one of the exams. So what are the most common form of presentation of myxoma? Because people, they tend to not study this topic very well because they think that the cardiac tumor is rare, but this is a very hot topics to be asked in exam. So you need to know what are the most common constitutional symptoms, which is fever, weight loss, fatigue, malagia, weaknesses, and arthralgia. And why the patient have a constitutional symptoms? Because they have a circulating interleukin 6 and tumor antibodies complexes that activated the complement system, and this lead to constitutional symptoms. Also, this patient could present with cardiac arrhythmias and sometimes sudden cardiac death and infection. So how we diagnose? This is tumors. Sometimes it's a tumor, like when you listen to the heart, you hear a tumor blob, and this is sometimes confused with S3 or like heart failure. So you have to be careful. And sometimes in the EK you find big A waves on the GVB. If you have a very big right atrial myxoma, I know most of the common it's present in the left side, but sometimes present on the right side, and can actually show you a very high A waves, like Canon A waves on the GVB. Sometimes the chest X-ray you could see some calcifications in the X-ray. EKG usually is not specific. It could show you like large chambers, cardiomegaly, bundle branch block, excess deviation, but we don't really depend on. But if they ask you what is the gold standard modality to diagnose atrial myxoma, it's an echocardiography. And what are the things that we look into echocardiography? We look into the globular, mobile mass, smooth surface or irregular. It's friable surfaces with multi-lobular appearance, usually between 4 to 8 centimeters. And the most important things, you see heterogeneous echogenicity. You don't see the whole tumor as one echogenous mass. You see there is difference in the echogenicity and echolucence. And sometimes, as I said before, if this myxoma has been there for a long time, you can have calcifications. So sometimes CT and MRI is useful to detecting the intracardiac and pericardiac extension in terms of invasion or secondary tumors, and evaluation of ventricular masses that occasionally turn out to be myxoma. So you have to be careful. Even if you're dealing with myxoma, you should scan the patient, do a CT scan before, or MRI if it's available, before you touch this patient, because sometimes you get surprised. This is not a myxoma. It could be sarcomas, or it could be a myxoma, or it could be another kind of tumor, like such as metastasis tumor. So that make the patient inoperable. So before you embark on any operations, you need to work the patient up properly. This is as you see here, this is a mass, which is most likely a left atrial myxoma. And as you can see here, you see that the tumor is not one echogenic mass. It has different echogenicity, and you can see here there is some calcification at the wall of the tumor. So this is very important when you see this. Also, could be also sarcomas. Sometimes sarcomas can present exactly the same way. And actually, we operated in a patient like this as a myxoma and tend to be a sarcoma. Let me see if this video will work. Yeah, nice. So as you can see here, this is long axis parasternal view, and you can see here this is the left atrium, left ventricle, mitral valve, aortic valve, RV, and you see there is a mass in the left atrium that it's mobile. It has multiple echogenicity. So most likely or highly, you have to keep in mind that this patient has an left atrial myxoma. I hope this works. Okay, it does not work, but the idea of this myxoma is huge, and it's protruding through the mitral valve. And this is when the patient presented, if you remember, we say 67% of the people presented with heart failure symptoms because of this, because this tumor, it obstructs the outflow for the mitral valve and will cause severe heart failure symptoms. So the management of left atrial myxoma, we spend most of the time with left atrial myxoma because this is the most common tumor, and this is the most common tumor they're going to be asking in the exams, and this is the most common tumor they're going to operate on. That's why we spend most of the time in this, talking about this. So the gold standard management of the little air myxoma, it's always a surgery. Okay, you can if a patient diagnosed with the left atrial myxoma, this patient should not be left alone. This patient should have an urgent operation to prevent stroke, because if this patient presents with a stroke, sometimes it will be tricky because you have to wait for a couple of weeks till he healed because of risk of bleeding. So when you get consulted for a patient with left atrial myxoma, this patient should be operated as soon as possible. So surgery is the gold standard, and it's actually the only option. So if you talk about how we're gonna do this operation, some people, they say just go from the right side. I would recommend you not to do this, especially in the beginning of your career, because I have seen actually a case when the surgeon goes only into the right side and he cut into the mitral valve, and we have to repair the mitral valve, batch it, and then batch the interatrial septum. So always open both atria and look from both sides, because sometimes this tumor originates very close to the mitral valve or very close to the conduction system. And when you cut from the right side, you don't see exactly what's the interface in the left side, and you could end up with damaging some important heart structure. So you do biatrial approach. You have to make sure when you excise the myxoma, you have to take part of the septum, out, because you want to make to have negative margins. And most of the time, you need to batch the anterior septum. Okay. Operative mortality, it's 5% or less. As you remember, we said that in the non-familial, which is 80% of the time, there's very low recurrence rate, between 1 to 4%. However, in the 20%, which is 5% of familial and 15% non-familial, but they have abnormal DNA, the recurrence rate is high. And this is also could be another hot exam questions. It will be the recurrence rate range between 12 to 40%. As you can see here, this is approach from the only left side, and this is also taken from cone. As you can see here, this is if you imagine as a surgeon view, you have SVC, IVC, okay, and they have here the retrograde cannula. But in these cases, to be honest with you, you don't need to give retrograde. If you give a good shot of antegrade, and then because you need to open both atria. So this is one of the approach, because as you see here, you have to imagine, because when you look into intra-atrial septum from the left side, you have to look into the roof of the left atrium, because the septum actually lies in the superior part of the atrium. So you have to really flip the atriotomy to be able to look into the myxoma. But some people do a T incision. What T incision mean? They open the right atrium longitudinal, and they open the left atrium as transverse, and then they meet together and they resect the septum. This is this is another option. Other option is just to do transverse in both atria, and then close each atrium alone after batching the septum. So there is multiple. Some people advocate to do it only from the right. Some people advocate doing it from the left. Some people do always the biatrial approach. I recommend you to do a biatrial approach in the beginning. Not only beginning, all the time, just to be safe and make sure that you don't injure any stuff in the heart. So this is myxoma. Any questions before we move forward?
No, thank you.
Okay. So other benign tumors. So we have the tumors that originate from the fat, as we discussed before, such as lipomas. It's well-encapsulated tumors. It may occur anywhere, the lipoma. It could occur in the epicardium, subendocardium, subepicardium, or could be, occur in the atrial septum. It's slowly growing. The subepicardial and parietal lipomas tend to compress in the heart. Okay, this is very important. And sometimes it's associated with the pericardial effusion. The subendocardial tumors may produce a chamber obstruction. So you have to understand. So So if the patient presented and you have a suspicion of lipoma, then from where this lipoma it's locate, you could actually anticipate the presentation of the patients. And most of the time, when you resect these tumors, they don't have a recurrence rate. We have something called lipomatous hypertrophy of the intra-atrial septums. This is very important, and don't be like this is also all these tumors. It's good to know about, okay, because you might be asked about where does it occur. Most likely in elderly female. It's non-capsulated. The most form of diagnosis you do an MRI. Why it's important to deal with these? Because sometimes they can present with arrhythmias and heart block, and this is the time when you need to resect them. Biliary Fibroglystoma. This is one of another important tumors, because as you remember, this is the third most common tumor on the adult. So this arises from cardiac valves or adjacent endocardium, but most commonly seen in the aortic valve. Actually, so far I saw 4 cases of this tumor. It can embolize and cause MI or stroke. Some reports said it's associated with cytomegalovirus. Resection, if you diagnose it, you have to resect it. And histologically, if you look at it from its name, it's a papillary band of avascular collagen and elasticins with multiple polysaccharides covered with endothelial cells. There is a paper from Anesteco, which is recurrence rate after 3 months in 1 in 23 patients. So it's like 4.3% recurrence rate. I hope this works. I'm sorry guys, but sometimes you have issues with the... This is a fibroelastoma on the mitral valve actually, but it does not work, sorry. So this is one of the cases actually I did in Canada. As you can see here, we retracted the valve and then we could see the tissue. Sometimes even this, one of the cases actually was smaller than this tumor, okay? But this is one of the differential diagnoses of infected endocarditis. You know, patient presented with a stroke, and then they do echo. Echo showed there is a mass on the aortic valve, but the patient does not have any white count. He has no fever. So this is one of the differential diagnoses you have to keep in mind. Okay. Other benign tumors, rhabdomyomas. Rhabdomyomas, if you remember, when we talk about children, this is most common benign tumor in children. It's very important that if you remember when you did your pediatric rotation, something called tuberous sclerosis. Tuberous sclerosis, 50% of these patients, they have tumors. So tuberous sclerosis, you need to know what's tuberous sclerosis. What are the clinical features of tuberous sclerosis? Because you might be asked. So it's associated with seizure, mental retardation, and the sebaceous cystis and rhabdomyomas, okay? And sometimes this can happen in the heart. So we're going to ask you, where does the rhabdomyomas most likely occur? It occurs most likely in the ventricle, and 30% of them occurs at the atria. Rhabdomyomas, it can cause valvular or subvalvular stenosis and can cause arrhythmias. Because it occurs on the atria and ventricle, they can cause both. They can cause, sorry, they can cause ventricular arrhythmias and they can cause atrial arrhythmias. So if a patient is symptomatic, which is often are multiples or extensive. So if a symptomatic patient, when they present with symptoms from rhabdomyomas itself, that means this rhabdomyomas is multiple or very extensive. And you have to keep in mind, if this rhabdomyoma is most likely associated with tuberous sclerosis, this is dismal prognosis. So most likely this patient will not be operated. Fibroma, this is the second most common in children. After fibromas are non-capsulated here and firm, nodular, gray-white tumors that can become bulky. This is very important because fibromas sometimes can present it with very big tumor. And how does it look histologically? It's a broad spiral band mixed with collagen and elastin. Sometimes in fibromas you can have a calcium disposition, and as I said, it can present it either with, if it's too big, it can cause compression, or if it's close to the conduction system, it can cause arrhythmias. If it's local disease, it can be resected. Extensive tumor need to be actually transplanted. And as you can see here, you see this how this fibromas taking most of the left ventricle. Okay, so these tumors, you cannot resect the ventricle, right? So, and extensive. So some of these people ended up with heart transplants. What is the other benign tumors? Other benign tumors. Now, when we go down the list, this is actually less. This is like very less, and but you need to be aware of these kind of tumors. Okay. So mesothelioma of the AV node, it's a polycystic tumor, Purkinje or conduction tumors. It can cause heart block or VTAC. ICD does not prevent fibrillation. Surgical excision has been reported, but usually these patients they will have like a sudden cardiac death. Phenochromoscytoma, as you know, phenochromoscytoma, it can happen anywhere, you know, like along with sympathetic nerve system, but sometimes can happen in the heart, and you have to keep in mind this is a very, very high vascular tumor. So it arises from Kaufman cells, and this is important, you need to know, on the sympathetic nervous systems, and produce a very excessive amount of catecholamine, particularly norepinephrine. That's why the patient sometimes presented with uncontrolled, if the patient have uncontrolled hypertension and have mass in the heart, always think about phenochromoscytomas in the heart. Patients usually presented with symptoms of uncontrolled hypertension, as I just said, or are found to have elevated urinary catecholamines. The tumor usually located, you can do a scintigraph with iodine 131 using CT scan or MRI. Cardiac catheterization with different blood chamber sampling sometimes is necessarily, and also in adding to the coronary angiogram. So that's like you're doing a hemodynamic study. So you get into your catheter into the aorta, into the LV. You put then you put an RV, like what you call it, Swan Ganz on the right side, and then you measure all the different chambers, blood pressure, on top of the coronary angiogram. Because sometimes when you inject in the coronary angiogram, you could see the blushing of the tumor, which we will see in the next slide. Paraganglioma, this is also another high vascular tumors. It's endocrine tumors. It also can be secreted of the catecholamine, and most likely located into the posterior mediastinum. Okay. So as you can see here, this is a coronary angiogram which showed a very vascular tumor, which is most likely a phenochromoscytoma. And here, as you can see in this, this is a paraganglionoma, which is located in the posterior of the mediastinum. Both of these tumors producing catecholamines, and both of these tumors, the patient can have very uncontrolled hypertension. Going down the list, hemangiomas, it's another benign vascular tumors with variant presentation, can be presented with arrhythmias, shortness of breath. It occurs in any age, and it's very difficult to diagnose. Teratomas, as you know from histology, it's 80% are benign. It's most common in children. It's germ cell tumors and yolk sac tumors, and they can present it with hair and teeth inside the tumor sac. Another important benign tumor of the heart, it's called an accustomant tumor. Accustomant tumors, it's poorly understood tumors. It's actually a lymphoproliferative disorders. It's typically presented as solitary lesions on the mediastinums, and the most common histobiological type, it's hyaline vascular, which accounts for approximately 90% of these cases. and it's often behave in benign fashion. In the more aggressive type, if the patient presented with benign fashion lymphoproliferative disorders, this is usually hyaline vascular histologically. But if the patient have plasmas and mixed cells, this kind of tumors presented very malignant. Type of tumor presented with the lymph node in the mediastinum with well circumscribed mass and myocardial coronary artery invasion sometimes can develop, and this is what you call a coronary pseudoaneurysm. The only curative treatment for this, it's a complete surgical resection. This is very important to know about custom tumors, because this is also another important exam question. So as you can see here, this is a coronary pseudoaneurysm, which is related to this lymphoproliferative disorders. And this is another important posterior mediastinal mass, which could be, which is very rare, like teratomas. So before we shift the gear to malignant, any questions in the benign?
Yeah, kindly regarding the fibroelastoma, when it is in valve. So is it like subaortic membrane? Is it shaving? When I have to do aortic valve replacement, what is the trick while I'm removing this the fibroelastoma?
So most of the time you don't need to replace the valve because it's a small tumor attached to one of the leaflets. You have to shave it with a knife first. Mm-hmm. But sometimes if the tumor have a very big base, you have to resect part of the leaflet and then batch it. Most likely aortic valve. In the 3 cases I have seen, we did not replace the valve. We just shave it, and then if there is a small defect on the, either you can like primary repair it, or you can batch it with a pericardium. If it's located in the mitral valve is even easier because mitral valve is a bigger structure, and you can easily repair it. But if you're in your career, like, and you just you think that you're not gonna have a very good competent aortic valve, then yes, you should consent the patient for aortic valve replacement as well, possible aortic valve replacement.
Okay, and the pericardium I use, is it, I need to treat it with glutaraldehyde or just?
No, just fresh.
Fresh pericardium. Okay.
Because the problem when you treat it with the glutaraldehyde, it becomes very tough. Okay, it becomes stiff. And aortic tissue is very like mobile tissue and the frail tissue. So suturing tough pericardium to the aortic valve sometimes can be tricky. The suture can cut out. But you take a fresh pericardium and you just decrease the defect, close the defect.
Okay. Thank you.
Dr. Mohammed, معلش. Which valve is more affected by fibroelastoma?
Aortic valve.
Aortic valve.
Yes, this is the most common valve.
Okay, thank you.
But it can happen anywhere.
Okay.
So it can happen in the mitral, it can happen in pulmonic, it can happen in tricuspid, but it is aortic number 1, mitral number 2, tricuspid number 3, and pulmonary number 4.
Okay, thank you.
Any other question?
Yes, excuse me, Dr. Mohammed. In your 3 cases which you saw, is it incidental findings or pre-op you find it? I mean, concomitant with
No, it's a pre-operative.
Two
Two of the cases which actually suspected as fibroelastoma. One of the cases was suspected infected endocarditis, and turned out it's not infected endocarditis. So it was fibroelastoma. But you're not gonna go after the valve unless there is something, right?
Okay.
Because either it's gonna be like a suspected infection or it's gonna be a mass. If the patient presented with no symptoms whatsoever, no white count, no fever, nothing, then you suspect fibroelastoma. Or if the patient presented with a stroke and a mass in the aortic valve, this is another clue that the patient has fibroelastoma.
Okay, thank you.
Okay, guys?
Okay.
So malignant tumors, as we discussed before, 75% of them are sarcomas. And you need to know what are the most common sarcomas that you're going to face. The most common one is angiosarcomas, followed by rhabdomyosarcomas, malignant mesotheliomas, and fibrosarcomas. So as you can see here, this is also a table was taken from Cohen. The most common tumors, it's angiosarcomas, followed by rhabdomyosarcoma, mesothelioma, fibrosarcoma. And then as you go down into the list, you could see that you can have any kind of benign tumors, such as lymphoma. This is very important actually. Sometimes lymphoma can present as a cardiac tumor, or osteosarcoma, thymoma, neurogenic sarcomas, leiomyosarcoma, liposarcoma, synovial sarcoma. So this is very important because how does this patient present? So the most common form of presentation, it's dyspnea. It's about 62%, which is followed by chest pain, followed by congestive heart failure. The patient can present with palpitation, fever, and malaise. And as you know, these people present with fever and malaise because they will have a complement system activation due to antigen antibody of the tumor complement, or due sometimes these tumors produce an inflammatory response material such as interleukin-6, anti-TNF, and all this stuff. So when we talk about sarcomas, we divide the sarcomas according to the side of the sarcomas. Is it right sarcomas or left sarcomas? Because these two sarcomas actually behave different. So right sarcomas, they metastasize early, they have bulky mass, they're infiltrative, and as you know, the heart failure on the right side, it can start in late stage because the RV and the right atrium, it can actually adapt for high blood pressure more than the left side. So you have some time to treat them with chemotherapy before you do a surgical resection. However, the left sarcomas, they presented as less invasive, metastasized late. However, they're prone more to obstruction. So you don't really have a lot of time to treat them with time for chemotherapy. So these guys, they have to treat them with early surgery. As you're going to see during my presentation, we talk about something called autotransplantation, when you take out the heart, resect, and then bring the heart back. And even if you're not going to do autotransplantation, you're just going to do transplantation for the heart, still these guys have a very poor survival. Like their median survival after heart transplant is 12 months.
Oh, this is somebody's around? Okay. I will come here.
So
Who is this?
right sarcomas, left sarcomas. Left sarcomas, most commonly it's angiosarcomas. It occurs most commonly in the right atria. It can involve the right ventricle, tricuspid valve. It can involve also the RCA, which is the coronary. As we said, we could use something called the neoadjuvant chemotherapy, which is before the surgery, and then you resect them after the chemotherapy because you want to improve their survival. They also sometimes they involve SVC and IVC, but sometimes you need to do a femoral cannulation for better exposure of the caudal atrium, or like the lower part of the atrium. Imagine if this is tumor going to the IVC, right? Sometimes you cannot cannulate the IVC from the heart. So you always have to have an innovative cannulation strategy, which you can do percutaneous femoral, and you can do percutaneous jugular cannulation. So by this, you have the patient totally drained, but you have the whole atrium to reconstruct. The left sarcoma, it's also occur in the atrium, and 92% of the time, and the remaining will be occur in the left ventricle. And most common presentation, it's, as we say, obstruction. You diagnose it with a CT, MRI, echo, and PET scan, and it's very the left side, they have very poor survival. Like the surgical survival at 1 year it's 20% with surgery. Without surgery, it's even worse, like 10%. So you improve their survival by 100% when you operate on them, but it's also still very dismal. As you can see here, this is how this sarcomas originate from the right side of the heart, and it's like a huge mass. Even opening the chest and accessing the heart is actually sometimes challenging, because these masses actually sometimes adherent to the chest wall. So you have to deal with them like you do a redo. You have to do subternal dissection, shave out the tumor from the chest wall, and then you'll be able sometimes to resect these tumors. And as you can see here, this mass is originating into the body of the right atrium. So this is which we left atrial sarcoma. Here we're looking into the back of the heart. You see, we're not looking into the. This is the front of the heart. This is the back of the heart. Okay. So as you can see here, so go back a little bit. So here you deattach the SVC, you deattach the aorta, you deattach the right pulmonary artery, because as you remember, the roof of the pulmonary of the left atrium, it has a very close proximity with the SVC, with the right pulmonary artery, and even with the aorta. So sometimes to be able to access this, you have to cut all this structure to be able to do this operation without taking the heart out. And then you flip the heart, then you resect part of this left atrial sarcomas, you patch this, and then you have to, as you see here, you patch the left atrial myxoma, left atrial sarcomas, and then you reconstruct the pulmonary vein confluence with the graft, reconstruct the PA with the graft, reconstruct the aorta with the graft, and reconstruct the SVC with the pericardium. Like you take a pericardium and you make it like a tube, and then you reconstruct the SVC, because it has a very high tendency to thrombose. This is one of the ways to do this without taking the heart out. Sometimes the myxoma, it's extensive, and you cannot actually resect it while the heart's still there. Then you have to do what you call like auto-transplantation. This is how, like, you deattach SVC, you deattach IVC, deattach aorta and PA from the trunk, and then you flip the heart and you start deattaching the left atrium. As you can see here, this is how you develop the influence for the pulmonary veins. And here is the mitral valve. So now you take the heart totally out, and you can see here, this is the mitral valve annulus. You put ablated stitches into the mitral valve annulus, and then you bring a big bovine pericardial patch. You make a hole corresponding to the same hole of the mitral valve, and then you pass the stitches into the patch first, and then into the mitral valve. And then you tied the mitral valve with a patch into the mitral valve annulus. While you're doing this, after you finish this, you want to make sure that your circ is fine and you don't cause any problem. So you put your antigrade cannulas into the coronaries, and you give bleach just to check the heart. So we finish the heart part. Then you go now to the left atrial part. Now we develop this confluence, and this is back on the posterior of the mediastinum. Then you resect the left atrium with the tumor all the way, and then you take another patch, which you make it like, and then you suture it to the pulmonary vein confluence, just to reconstruct the back wall of the left atrium. Sometimes the tumors, it's very extensive, and you ended up only with the influence of the pulmonary vein. Then you have to reconstruct the pulmonary veins separate. Like sometimes if the tumor involving one of the pulmonary vein, you have to resect it and you have to reconstruct it. And after that, as you do a transplant, you have to orient the heart with the new confluence developed, and then you suture that new patch, the new patch or the new atrium again back together. After you finish this, you flip the heart, and you do as you do the sequence of the transplant. You do the IVC, SVC, PA, and you ended up with aorta. And as you can see here, this is the final result. It looks easy in drowning, but it's very, very, very complex surgery. So in malignant tumor, as you said, angiosarcomas, it occurs 80% of the right atrium. As we could see, it's bulky tumor, as I discussed before. It can involve anywhere, RV, TV, RCA. At diagnosis, usually it has metastasized already. And what are the most common site of metastasis? Is a lung, liver, and brain. As I said, these kind of tumors, they have the neoadjuvant chemotherapy. You start with chemotherapy. Or sometimes if the patient cannot get the chemotherapy, then you operate on them and then you give them a chemotherapy. It's very aggressive tumor. Prognosis is poor. Without a resection, 90% will die within 1 year, despite radiation or chemotherapy. Malignant fibrohistiocytomas. This is the most common soft tissue of sarcomas in adults. It's polygonal cells resembling histocytes. Sometimes you can see fibroblast and histoblast inside the tumors. This is very important because sometimes most common occur in the left atrium and sometimes it's mimic the myxoma, and this is one of the differential. That's the patient have a malignant fibrohistiocytomas. Usually no mets at diagnosis, and adequate surgical resection can be achieved because these tumors, they did not metastasize and will be localized into the left atrium. Now, rhabdomyosarcoma, there is misconception or misunderstanding that these tumors will develop from rhabdomyoma. It does not develop from rhabdomyoma. It's actually it come as a primary entity. It's 60% developed from either ventricle, and it can also invade the cardiac valve, which is most likely the tricuspid valve or the mitral valve. Microscopically, tumor cells demonstrate as a polymorphic nuclei, and which is spidery, wispy, streaming eosinophilic cytoplasm. Usually, it's because it looks like a muscle because it's rhabdomyosarcoma. It's very aggressive. If the patient have small tumor, you can resect. If it's locally invasive, you have to treat it with radio and chemo. Other tumors, including myosarcoma, liposarcomas, osteosarcomas, chondromyosarcomas, blastocytomas, and carcinosarcomas. If the patient have a lymphoma, and then the patient presented with lymphoma in the heart, their main treatment is non-surgical. It's it's radiotherapy and chemotherapy. Now, there is another important entity, which is pulmonary sarcomas. This is tumors originate into the pulmonary artery, actually. Okay, this is also have it's resectable tumors, but it is it's very aggressive tumor. So if you have this is the algorithm of initial evaluation of any patient with pulmonary artery sarcomas. If there is a pulmonary artery filling defect in a CT scan, this patient should go for gadolinium enhanced MRI to assess the tumor. Then the main treatment depends on the stability of the patient. If the patient is stable, you treat him with chemotherapy with adrenomycin and isofamide for 2 cycles, and then you send them for a radical resection. However, if the patient is unstable, that means the patient presented with any signs and symptoms of RV failure because of this obstruction, the PA, then this patient should go for surgical resection. So we have also staging system for the primary pulmonary artery sarcomas. So we have stage 1, stage 2, stage 3, stage 4. If only involved the main pulmonary artery without involving the branches, this is stage 1, and this is the best prognosis. If the patient involve 1 lungs plus the pulmonary artery, this is stage 2. If it's involving both lungs, this is stage 3. If you have extracardiac spread, this is stage 4, and this is metastasized. So most common presentation, as I said, it's short of breath and RV failure. Sometimes it's very important. It can be mistaken with pulmonary embolism and can be treated with thromboendarterectomy. It originates from the base of the pulmonary artery just after the pulmonary valve. And histologically, it's coming from mesenchymal cells. And as you remember, guys, where does the PA originate? Embryologically, it originates from the bulbus cordis. That's why it has a mesenchymal cells origin. It grows distally into the artery, and that can involve, as I said, the lungs. And this will depend into the staging of the tumor. The only way to increase the survival is a surgical resection. As I said, for surgery, you need for sure you need a cardiopulmonary bypass machine. You have to have a bicaval. Sometimes you have to cut the aorta. Why we need to cut the aorta? Because you need to access the right pulmonary artery. Because as you know, the PA will originate from the RV, and then the main PA and the left will go to the left, and this will be easy to access. But the right pulmonary artery will take a course behind the aorta and behind the SVC and on top of the left atrial dome. So this is very important anatomical structure that you need to be aware of. You may need sometimes a pneumonectomy if the tumor is involving going very deep into the lung, and you cannot really resect it from the pulmonary artery. You have to do you have to open the PA, resect, take the tumor out, cut the stump of the PA, and then do a full pneumonectomy. So if you operate in these patients, you have to fill them up. And look, the first year, they have to be seen every 3 months. They have to be scanned for 3 months. From 1 to 2 years, they have to be scanned every 3 months. From 3 to 5 years, they have to be scanned every 6 months. From 5 to 10 years, they have to be scanned yearly. After 10 years, if they're survived, they will be scanned if they have symptoms. So any positive scans, you have to have a contrast enhanced CT. If there's any PA filling defect, they go back, as we said, calodinium MRI. If there is tumor enhancement, you have to take him back for another surgery. Now, what are the most common malignant cardiac tumor? It's metastasis tumor. 75% of the tumor in the heart, malignant, it's metastasized. 25%, it's primary. So what are the most common metastatic tumor? This is another important question. This is an exam question. So the most common metastasized tumor is leukemia, melanoma, lung cancer, sarcoma, and breast, followed by esophagus. If you go through this list, and this is also taken from Cohen, you can see that the percentage of each tumor, but you need to know the most common 4 important tumors. How these tumors metastasize, it has 2 routes, either hematogenous, through the blood vessels, or lymphatics, which go through the lymphatic. Hematogenous, this goes via the coronary arteries, and this is very important, the melanoma and the sarcoma and the bronchogenic tumors. Lungs, breast, esophagus, and thymic, this go through the lymphatics. Sometimes you have local spread, such as the patient have esophagus tumors or breast tumors or lung tumors. This is close proximity to the heart. Sometimes these tumors can split locally. So the most common representation of these tumors when you have when it's metastasized is present with effusion and tamponade. It can also present with the CHF and arrhythmias. There is no surgery, because when the patient have metastasis to the heart, that means this patient is stage 4 cancers, primary. So these patients, we don't operate on them. We just do surgery to relieve the symptoms. Either we do a subxiphoid window, or we do a pericardial window through the left thoracotomy. As you can see here, this is a cardiac metastasis in the autopsy. You can see here there's multiple tumors in the heart. So sometimes there is an abdominal tumor, which is in forms of renal cell carcinoma. This renal cell carcinoma can going into the IVC and into the right atrium. I have seen actually 3 cases during my training, 2 in Canada, 1 in the States, and we operated in 3 of them. So you have to put them on. You have to put a cardiopulmonary bypass machine. Then you have to cool them down, and then arrest the circulation and take out the tumor. So most commonly, you have to know this. Most commonly, it's renal cell carcinoma. In the renal cell, it's actually in the renal cell carcinoma. It's only 10% of them involving the IVC, and out of this 10% that involving the IVC, 40% of these 10% will reach into the right atrium. If this patient presented with tumor that reaching the right atrium, they have to go for stenotomy and deep epithelioid circulatory arrest. Not all IVC involvement will have will have cardiac surgery involvement, but if it's extensive and reaching the right atrium, they will need a sternotomy, deep hypothermic circulatory arrest. They have very good survival. It's like up to 75% into 5 years. I think that's it. Thank you so much.
Thank you very much.
Thank you, Dr. Mohammed. Thank you.
It's a lot of information, but this is a full review. I mean, if you read all these slides as you review the whole topic, actually. Any question?
Nothing from my side. I don't know about the others.
So let me finish this presentation.
Thank
Okay,
you.
let's see. No questions?